This is Blood and Cancer, the official podcast of MDH Hematology-Oncology. I'm the voice of MDH Podcasts, Nick Andrews.
A few weeks later, she passed away in the hospital, even though she had said before that her preference would be to die at home. We had talked many times, and we couldn't seem to reach any agreement. Even months later, I have trouble making sense of everything that happened.
But there still isn't the kind of meaningful access to palliative care that we would hope for there to be for any patients with cancer, especially advanced cancer and serious illness. And so you have to be judicious and you have to kind of decide.
Welcome to episode 52 of Blood and Cancer, the official podcast of MDH Hematology-Oncology. I'm the voice of MDH Podcasts, Nick Andrews, and I'm joined, as I typically am, by Dr. David Henry. Dr. Henry, I, of course, had my eye procedure done, and you were on hiatus for the holidays as well. Did you have a happy and safe Christmas, Hanukkah, New Year?
Well, happy and safe Christmas and New Year, and the family came and gave gifts and a cold. So I'm getting into the second week of my cold, which everybody seems to say is about 2 weeks. And so I can't complain much after that, and I'm so glad you're back and had a good procedure.
Yes, health and happiness. It is... For those who don't know, being a donor recipient is a really weird thing to think about. I'm not going to sugarcoat that. It's a gift. That's certain.
Well, you deserve it, and I'm glad it went so well.
Thank you. I appreciate it. So it's good to be back in the swing. I've been gone for 3 weeks officially. We had some best of content. Anytime we have the opportunity to do that and highlight Dr. Yurkiewicz for clinical correlation, that's a good thing. But Dr. Yurkiewicz is back with new material this week. This week, she wants to talk about times when patient families perhaps are too aggressive. Her specific example is a spousal situation, but I think that families typically, or not typically, but could sometimes have a difficult time grasping what the patient has grasped long ago.
Yeah, and I think of it as the pushy family where either, just as you said, the spouse or family member says, of course you want another therapy. Of course, don't you want to live? And this poor patient is coming to the end of the line and is really unhappy, uncomfortable, sad, dealing with what's coming, and really doesn't want to be pushed. And the other is sometimes when a family member just runs the show, you're trying to talk to the patient and son, daughter, whomever, significant other keeps answering and saying for the patient. So Ilana covers another good topic.
Yeah, of course. And it was good to get some FaceTime. All of us, of course, we met up at the American Society of Hematology in Orlando. So Dr. Yurkiewicz, best of content was available last week. New stuff that is after our interview this week. And it's a great topic. It's great synergy this week. I'm going to take all the credit, even though it was our fearless editor, Mary Ellen Schneider, because the topic in the interview this week is palliative care.
Yeah, and we talked with Dr. LeBlanc, who's a specialist in this area. And I must say, I learned a lot from my interview with him. I have a palliative care team in my hospital, and sometimes I may be guilty of thinking, well, they're doing something that I should be doing, and it's my job. And he said, well, we kind of do a different approach. It gives them sometimes what he called a safe space, a free area where they can talk and say things maybe they don't want to say to you, Dr. Henry. And I said, you're right. So I think used and consulted appropriately, they're really helpful.
Yeah, I guess that's one of the questions I have for you, not just with this interview, but in general. Do you think that you get off the phone with some of your interviews, or you get home and you think to yourself, wow, I can apply this directly the next day?
Absolutely. I'm really blessed because not only do I get to enjoy working with you and these wonderful people in hematology, oncology, blood and cancer, but I learn. So I hopefully give as much as I get.
Well, that's what I like to hear, of course. Happy New Year to you. It's 2020. I had my eye surgery, so I see 2020. There's a metaphor in there.
I like it.
Yes, you like that. There's a nerdy joke right there that I think everyone will.
It's good. We'll use it again and again.
For at least for a calendar year. Coming up later this year, we're going to cover a bunch of meetings. We're in our second year, 1 year anniversary coming up in a couple weeks, so we might do a retrospective and look back at some things, but it's been a great journey, and we welcome you all to 2020. Let's talk about this interview coming up right after this.
Stay tuned. I'm Dr. David Henry, your host of the podcast Blood and Cancer, to which you are listening. We are an online journal, mdh.com/hematology-oncology, where you can read many articles of interest, where you can review blood and cancer podcasts in the past, and certainly the one from today, which without further ado, I'll introduce my joining hematologist-oncologist Dr. Tom LeBlanc, who is Associate Professor of Medicine at Duke Cancer Institute. And Tom, welcome to the podcast. Thanks for taking the time to join us today.
Thanks so much for having me.
You're very welcome. So our topic today is palliative care, and that's so broad, and dissect where that goes. I'm a generalist, a practicing hematologist-oncologist, and seeing patients all the time. And of course, with cancer, heme malignancy, or solid tumor, things don't always go well. And so we quote, in fact, the house staff will say, do you want PAL care to see the patient? So I think it's really important to talk to a specialist like you about what does that mean. So maybe we could start with, what's the palliative care team? What is your role in it? And then we'll start to dissect that.
Yeah, this is such a great and important question. So palliative care as a field has evolved just exponentially in really about a decade. So now it is a board certifiable subspecialty where you have to do a formal fellowship training program if you're a physician doing specialized palliative care training and hoping to sit for boards. But actually, there are many different kinds of clinicians who are part of the palliative care team, too. We tend to favor a definition that has been actually tested with public opinion polling from a group called CAPC, or the Center to Advance Palliative Care, where they just asked American laypersons, if you were seriously ill, what do you think about this or that or the other in terms of the kinds of services you might want to have? And through that, they distilled a definition that best characterizes what we mean by specialist palliative care in the 21st century. And key components of that include that first, it is specialized medical care for people with serious illness. So it need not be a terminal illness. It could be a chronic serious illness like heart failure, for example, or maybe a more chronic cancer like CML, where we might expect the person to have a normal lifespan, but wherein they may have significant needs that a palliative care clinician could address. Other parts of the definition include that it is really aimed at maximizing the quality of a person's life with whatever the time they have. And so that means it can be provided along with even curative intent therapy. So a person in my world of practice, for example, could have an acute leukemia and be getting intensive induction therapy with the hopes that maybe we could cure them, but it's not a guarantee, and they could receive specialist palliative care services as part of their treatment to help them feel better while they're going through that difficult experience. So this kind of care is provided now often in consultative settings in the hospital or in specialized clinics, just like a cardiology clinic or infectious disease clinic might be involved in adding specialist input to the care of a person with cancer. But it's not only physicians providing this care. Sometimes it's APPs, like nurse practitioners and PAs, and it truly is interdisciplinary care where it's not just about the patient, but also about the family and the caregivers, wherein sometimes a social worker, a chaplain, a pharmacist may be more important members of the palliative care team for that particular patient and family, depending on where they're at in their illness and what their particular care needs are. So just kind of to summarize, in a decade, really, we've gone from a time where palliative care just meant death and dying and kind of was another word for hospice, where now it is this sophisticated medical subspecialty with a growing and pretty large evidence base now, where we're now grappling with issues of when do we call and who benefits the most and who should see the patient, knowing that we don't actually have enough palliative care specialists to see and touch every person with cancer, never mind serious illness.
Well, that really helps me. I actually, even though I'm already practicing and involving palliative care a lot, it helps me understand better. I'm kind of thinking, as you just spoke, the patient needs to get from here to there. And from here to there might be serious illness, death, and dying. You've had fourth-line therapy for your lung cancer, and things are just not going to go well, and the patient and the family need to be brought to that point. But from here to there might be your AML therapy, where we're going for cure, and you have serious side effects and needs, personal, family, etc., along the way. So you might even fold in the term symptom management as opposed to palliative care. So the main heading would be the palliative care, and then where are we and where do we want to go? And then you step in.
Absolutely.
So let's take it then I'm thinking more of the hospital, first of all. So we have a patient who is seriously ill, let's say, who is not doing well from the cancer. So from here to there is probably not going to be from here to cure, but from here to there, the grasping with this chronic illness and symptom management and not doing well. I've seen the patient for a couple of years and taken him or her on this journey, so they know and trust me a lot, and they're meeting someone new. How do you handle your role there in this patient destined not to do well?
Yeah, this is one of the major challenges of palliative care. And as we reflect a little bit on the definition that I just provided to you, there are probably a lot of things in what I said that you may think, well, you know, when I'm the oncologist treating the patient, I'm doing those things too. So who does what? Mm-hmm. And that's been one of the toughest areas to sort out, and maybe one of the barriers to earlier referral and integration. The randomized trials that have been done about early integration of palliative care, and really early means at time of diagnosis of advanced incurable cancer, typically. So this might be a newly diagnosed metastatic non-small cell lung cancer patient. So even, in the first line setting where you expect you aren't probably going to get to cure, but maybe this person could have a few years of life and some good quality of life with intermittent treatments, and we're kind of making decisions about those trade-offs and balancing toxicity and quality of life and length and such. So as the oncologist, we do aggressive symptom management. We provide supportive care with antiemetics and pain medications where needed. We manage people's symptoms. So I tend to think about the palliative care specialists being most helpful for situations where it's more complicated and the usual things aren't working as well as we want and need them to. And indeed, the randomized trials have shown that one of the major areas of benefit is in better symptom management, particularly in those people with multiple or more severe significant symptoms, where we're trying all of the things we usually try and the patient is still struggling and we're not sure what else to add for their, say, refractory neuropathy or chemotherapy-induced nausea and vomiting after they've gotten all of the standard guideline-appropriate therapies. Another area that palliative care has shown to be an augmentation of what we're already doing when we're providing excellent comprehensive cancer care is in coping and psychological well-being. So some of these trials have shown actually that patients will tell the palliative care specialist different things than they will tell the oncologist. So if I'm the person treating the leukemia patient and I hold the keys to the chemo, maybe they're not going to tell me how much they're struggling at home, because then I might stop their treatment, I might reduce their therapy, and the patient views that as their lifeline, their chance at maybe at cure. And that makes really good sense. Even though I'm somebody who has training in palliative medicine too, I can't actually really serve both roles for all of my patients at all times. And I often need that other person who can come in as a palliative care specialist and provide a safe space to explore those kinds of issues and uncertainties with the patient in a way where there's no threat of stopping the treatment and taking away the chemo. It's just what we call an extra layer of support. And actually that phrase, extra layer of support, is one of the things that came out of that public opinion polling that I mentioned earlier that really, really resonates with patients and families. Who doesn't want an extra layer of support when you're going through something difficult, right? So it's not as if we would say, I don't have to do symptom management, I don't have to talk about goals of care anymore now, I can just refer these people to palliative care, but rather it's augmenting it in cases where you need more help, where the usual things just kind of aren't cutting it.
Well, that really makes a lot more sense to me. I'm thinking of how I manage my patients. Let's take that non-small cell lung cancer metastatic who is not likely to be cured, maybe go through first, second line therapy and a lot of symptom management, but a safe space to talk to someone from a different perspective, the palliative care team, symptom management. I have thought, I should be doing that, but the way you just explained it, I think someone helping me, especially that would be an outpatient likely. And I'm thinking of our palliative care team run by several nurse practitioners who can really spend some extra time, let the patient and our family let it out, let their hair down, so to speak. And I still keep pressing on as hard as possible with that patient. Makes a lot of sense. So let's talk then coordination of that. So in that patient we've just posed, when should I get the palliative care team involved?
Yeah, and that too is kind of the other tricky dilemma that we have when there is a workforce problem in palliative care. So at this point, there are over 100 fellowship programs, and there are probably now well over 7,500 or so boarded specialists in the U.S., but there still isn't the kind of meaningful access to palliative care that we would hope for there to be for any patients with cancer, especially advanced cancer and serious illness. And so you have to be judicious, and you have to kind of decide, is it worth sending this person in front of me to come back another day to the clinic and pay another copay, and then, what are they getting from that? Or am I taking up a slot from somebody else who might really need that more? So some people have written about the idea of sort of trigger-based palliative care when certain things happen, like a disease progression, say a person who goes to an allo transplant who relapses. That would be more of a prognosis-dependent kind of a trigger for referral. Other times it's more recommended to be done on the basis of symptoms. So like I mentioned, severe refractory symptoms, that probably should be a good indicator of somebody who might benefit from palliative care services. Maybe a patient and family who are really struggling psychologically, they can benefit from that extra layer of support. So when you see those kinds of warning signs and flags, that might be a good time to think about a referral. But also, ASCO has come out with some recommendations. So in 2012, ASCO put out a provisional clinical opinion, which is kind of the precursor to a guideline, recognizing some of the emerging evidence at the time that probably we should be referring advanced lung cancer patients, at least, to early specialist palliative care. And then in 2016 or so, they formalized that into a guideline as many more trials started to come out around that time. And they actually have codified this in the recommendation that basically all patients with metastatic cancer should be receiving some flavor of integrated palliative care, or at least have that be considered around the time of diagnosis or progression. But like I said, with the workforce issues that we have, and especially knowing that there isn't much access in many parts of the community practice especially, it's a challenge to actually do that in practice. And so I have seen a lot more of and tend to favor the approach of saying, let's make this more needs-based around that individual person and their family and kind of how they're feeling and doing right now. The challenge there, though, is that you really have to pay attention and be cognizant of it each time you're seeing somebody and thinking, is this the time to refer, or what's my trigger going to be for this person, or why am I not sending them now? And is that, are they doing well enough with what I'm doing that they don't need that extra layer of support? And that's a really tricky thing to attend to when we're all really, really busy in our clinics and fighting with our electronic medical records all the time.
Boy, indeed. And I'm thinking, again, and we have a palliative care team, but of course they can't be everywhere. And what they do very nicely, which I suspect you do, is the palliative care consult is put in, whether outpatient or inpatient. They call me and say, hey, we're consulting Mr. Smith. What's his story and what are you thinking? Which I find really helpful. They don't go in blind saying, what did Dr. Henry tell you? That I just did tell them. How about this situation, which I see our house staff doing a lot? Patient admitted. We see the patient a little bit too fast sometimes in the morning because we're going to the outpatient setting, and the patient has pain. And the palliative care team is consulted by the house staff pain control. Is that a major role, a minor role? Do you like getting involved with that?
Yeah, symptom management is definitely within the core skill set of what palliative care specialists get extra training in doing. So really robust symptom assessment and aggressive symptom management with maybe sometimes actually unusual tools in their toolbox. So it might be that it's good to engage a palliative care specialist when a patient is on particularly high doses of opioids, or when you're getting uncomfortable with the level of the dosage, or when you're trying to add some adjuncts and maybe the person is having side effects or has some other contraindications and you feel like you can't manage their pain well. But typically palliative care specialists are happy to be called to help with cancer pain management. Oftentimes, though, we as the oncologists, when we're seeing patients, when I have that hat on, I'm usually comfortable doing the kind of preliminary pain management. But if it gets really complicated, there isn't so much time in the course of a visit when you're also dealing with the chemotherapy and the labs and the scans and the discussions about all that and the coordination of cancer care to then also be spending a lot of time and effort doing more kind of sophisticated, complex pain management. So I tend to think it's more those latter cases where it's most high yield to involve the palliative care specialist. And I think sometimes there is actually a tendency to say, this is a person with cancer pain. I won't have to prescribe opioids. I can just turf it to the palliative care doc, and then they can deal with all of that annoying, monthly prescribing and the checking the databases and making sure the patient's not diverting and all those kinds of things. And that probably isn't a fair use of the services, but I'll tell you that does actually happen in some places. So it has to be a balance.
I think of it as, you tell me if I'm doing this right or wrong, the palliative care team is consulted, and you need to use this long-acting drug and these breakthrough drugs, and we've titrated for you in the hospital, and this seems to be the right regimen, and maybe it's discharge day on Friday, and I go, okay, got it, thank you very much. Now I take that over. I'm going to see the patient outpatient, and I continue that regimen, tweak it as needed, as necessary for the symptoms. So is that the right way?
Yeah, I think that's a really great way to do it. And a lot of it depends on what you personally are comfortable with, too. So, some oncologists may be comfortable managing really high doses of opioids and using more unusual opioids like methadone, for example. And then others may get very uncomfortable pretty early on if a person has escalating doses of a long-acting opioid. And then, most of us are probably somewhere in between. Another example, too, where a specialist in palliative medicine can be really helpful is in the use of non-opioid therapies to augment the pain management. So they receive extra training in indications for interventional procedures, like, say, a celiac plexus neurolysis for a patient with pancreatic cancer who has severe visceral pain from their pancreatic head mass, for example. Those are things that we probably underutilize, frankly, in cancer care. We don't always have an anesthesia pain specialist there to do an intervention like that, but the palliative care specialists have usually seen and referred more folks for those kinds of procedures. And when those are feasible and they're effective, you can sometimes have patients totally off their opioid or on much less opioid, which typically translates into less side effects and usually better overall quality of life. You're managing the pain very well with less of a medication that might cause other problems for that person, like somnolence or constipation, or maybe they can't drive, or et cetera.
So that makes me think that could you suggest you may use these or have these memorized? We're all using apps these days. You ask a medical student a question, he kind of turns away and checks the iPhone and comes back with an answer. It's a new era. When you're doing, I've seen it happen. When you're doing pain management, of course, the side effects, constipation, so forth, is there an app you go to? I need to convert this amount of morphine to Dilaudid or vice versa. Anything you might suggest our listeners to put on their smartphones?
Well, I'm a little bit old-fashioned. I certainly have a smartphone, and I use it very heavily, but I have not gotten into the medical apps. So I'm probably not the right person to ask. I'm sure there are some good opioid conversion calculator kind of apps out there. I learned kind of the old-fashioned way of doing that I have a table in my head, basically, and I usually just kind of write it out on a piece of paper and do it in a few different ways to make sure I'm comfortable. Yeah, and I often will double-check it with a pharmacist if somebody like that is nearby in the clinic. But really a lot of this is more art than science. So with opioid conversions, the recommendation is to significantly dose reduce for what we call incomplete cross tolerance. And this is a concept that some people are familiar with in oncology, but some people have not heard of. It's basically the idea that if you go from one opioid to another, say the patient is on oxycodone, but we're going to rotate them to morphine, so that maybe we can prescribe long-acting morphine and short-acting morphine, and it'll be less expensive than a long-acting oxycodone or brand-name prescription. There's a conversion where you can look this up, and X amount of oxycodone converts to X amount of oral morphine equivalent, and but then the recommendation is to reduce that sum because there is this phenomenon whereby some people are more or less sensitive to a different opioid just because each person is different. So we have to be very careful about making those kinds of conversions, and that's often when involving a palliative care specialist can be particularly helpful. Similarly, in a patient who is on pretty high doses of opioids and getting ineffective pain relief or having escalating pain, sometimes actually what we see is this phenomenon whereby the person has sort of a hyperalgesia, which is sometimes alleviated by just rotating to a different opioid. And if you're using pretty high doses and doing one of these opioid rotations, as we call it, that can be kind of high risk. And yet sometimes that makes a really big difference in that person's pain control. So that might be something where you say, gee, this is a good time to get a specialist involved. And the way I tend to talk about this is to say, not every patient with a heart who has cancer needs to see a cardiologist. But sometimes we refer our patients with hearts to cardiology, not because they have a heart, but because they have a cardiac problem that's a little bit more unusual. So, it might be the patient who I've given a bunch of anthracyclines to for their leukemia treatment, and then their ejection fraction drops and they start having symptomatic heart failure. And I'm thinking, gee, it's been a while since I was a resident managing heart failure. I don't know if I should be the one prescribing their evidence-based heart failure regimen. Let me get somebody involved to help me out who knows this better than I do. Palliative care specialists are kind of the same way.
Yeah, I'm just thinking about how I'm practicing and how talking to you is going to make me change a bit. To summarize a bit, the palliative care team can get a different dimension for the patient. Maybe talk about some things they prefer not to talk about with me, and or you really resonate with me. I might turn off the chemotherapy and horrify them and the family. So they may want to go for broke with me, but talk about what if we don't get there with you. Symptom management. Where are we going? Is this someone in a curative setting or someone in an obviously not so curative setting and way out on the curve or in between? And then to use symptom management / palliative care, goals of care, and of course, pain management. You mentioned earlier in our talk some ASCO guidelines. We'll put that we have wonderful residents here at Pennsylvania Hospital, a couple of whom are budding hematology-oncologists soon in the fellowship, and they will do what are called show notes. So to remind our audience, on our webpage, mdh.com/hematology-oncology. Soon after this podcast, there'll be the show notes detailing some of the high points and bullet points that Tom has just given us. Mention that ASCO reference again that you mentioned, that they put out a preliminary paper on this.
This was the provisional clinical opinion, which preceded the guideline document. So that was in JCO in, I think, about 2012 or so. And then the formal guideline came out later. Okay,
so both are out. All right, so we can look at the guideline. And it's probably on NCCN as well as on ASCO guidelines. Well, I think
there is a palliative care guideline from the NCCN, and various professional societies and agencies have kind of guidelines and statements. So, for example, the Oncology Nursing Society has a statement that all patients with cancer can benefit from palliative care. The American College of Surgeons Commission on Cancer actually requires available palliative care services on site as a condition of accreditation for their accreditation process. So there are a number of different folks who've spoken out and advocated about this issue.
Yeah, and I suspect the ESMO, as you know, the European Society of Medical Oncology, and MASC, MASCC, I'm sure both would have this on their websites as well, and we'll put that in our show notes for readers to click. Well, I think we've really covered this and hit about the sweet spot in time of our podcast. Anything else you'd like to mention before we conclude?
No, just to say thank you so much for having me, and most importantly, thanks for the interest and coverage in this topic. There's so much exciting happening in personalized medicine and cancer care that sometimes we forget about these kinds of issues, and this is just such an incredibly important part of making sure that the patient experience is as good as it can be, whether we cure or whether we don't cure and anything in between.
Well, I thank you back because you've helped me just in our discussion of thinking how I best should use these services of these skilled and boarded professionals. And it's not just handing over the keys to the kitchen for this patient, it's to let them explore a different dimension in their care. So we want to thank Dr. Tom LeBlanc, Associate Professor of Medicine at the Duke Cancer Institute, for joining us today, and for all of you for listening. This is Blood and Cancer. I'm Dr. David Henry, mdh.com/hematology-oncology, and thanks for listening. Thank you, Tom.
Thanks so much.
And that concludes the interview portion of our show this week. Remember, if you liked the interview and you want to learn more about the topics discussed, there are robust show notes available wherever notes are available in your app. They include links to references mentioned in the conversation. When we come back, it's time for Clinical Correlation with Dr. Ilana Yurkiewicz. And welcome back. You're listening to Blood and Cancer, the official podcast of MDH Hematology-Oncology. It's time now for Clinical Correlation with Dr. Ilana Yurkiewicz.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. There was a patient I met a while back and found myself ruminating on recently. A few details of this story were changed to protect privacy. She had bad leukemia, and after a while and yet another relapse, she became pretty clear about her wishes. She wanted to go on hospice. She wanted to maximize the time she had left. She wanted to be at home, and she cared more about quality of life than trying to prolong quantity any further. When we talked alone, the two of us, these were her wishes. But every time we talked with her husband in the room, she grew quiet as he voiced his own wishes, that she would keep fighting, keep trying, and he knew she could get through it. She didn't seem to want to let him down, and so she stayed quiet and went along with it. It was heartbreaking for a lot of reasons. One was that both parties clearly cared about this patient. Her husband wanted what he thought was best for her, and he was clearly having intense emotional difficulty with the thought of losing her. These challenges, however, then clouded his ability to see what she wanted and what her wishes were. And she, in turn, went along with something she didn't want because she didn't want to let her loved ones down. She assumed the burden not only of her cancer, but of being the strong one, the fighter, so that she could assuage her family. We got a lot of experts involved, palliative care, social workers with experience in bereavement, but we couldn't resolve it. Her husband kept pushing, and she went along with his wishes. A few weeks later, she passed away in the hospital, even though she had said before that her preference would be to die at home. Even months later, I have trouble making sense of everything that happened. We had talked many times, sometimes me with her, sometimes me with both of them, sometimes me with the husband, and we couldn't seem to reach any agreement. In the end, it seemed that her husband had closure. Because she died in the hospital, he was assured that she did everything she could. She, quote, fought as hard as she could for life. But it still felt very wrong that her wishes had been so secondary. It's hard enough to have a terrible diagnosis and to accept hospice for yourself. It's that much harder when you have well-meaning loved ones not meeting you where you really are. I certainly don't have the perfect solution for this, but I hope this can be a reminder to family members that doing right by your loved ones means listening to what they really want. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that concludes the 52nd episode of Blood and Cancer, the official podcast of MDH Hematology-Oncology. It's a big year at MDH Hematology and Oncology. We'd like to thank each and every one of you for joining us throughout 2019, and we look forward to talking with you about the latest up-to-date information about hematology and oncology in 2020. Remember, for more hematology and oncology news, you can visit us at mdh.com/hematology-oncology. Dr. Henry and I and Dr. Yurkiewicz are all available on Twitter as well. Thanks for joining us. We'll be back next time with Blood and Cancer.